Bismillahirrahmanirrahim. Welcome back once again. We are going live at Lumps TV and FM Lumps. Now today, the third session of the today's conference is the Urolithiasis Academics, and for this I would like to request Professor Sajid Sultan Saab to please come on stage to chair this session, and Professor Safdar Khan sir, please come on stage. Professor Sattar Memon Saab is Dean Surgery and Allied Isra University Hospital, so please come on stage.
नहीं हो रहा है भाई. So Bismillahirrahmanirrahim. We will start with the session, and I will request Professor Zafar Zaidi, who will be speaking about the fellowship in urolithiasis. Professor Zafar Zaidi from Indus Hospital, Karachi.
Bismillahirrahmanirrahim. I'd like to thank the organizers for inviting me for this conference. We've talked a lot about management of stones, and I think without talking about the academic aspect of anything and the science behind it, we will not be able to progress in what we want to do. So the topic that has been given to me, so today I have been asked to talk about fellowship in urolithiasis. But before I say anything about it, I'd like to put up two questions. First is, do we need fellowship in urolithiasis? And my second question would be, what do we expect from a urolithiasis fellowship? And in trying to talk about them, we'll try and see if we can come to a conclusion that if it is required, then how should it be working. So when we talk about do we need a fellowship in urolithiasis, I decided to look at my own center, Indus Hospital, and the urology residency program, it's a high volume stone disease center. There's a proper organized structure residency program, and I looked at the CPSP logbook, and I'll be sharing with you how things are going. As most of you know who are supervisors, there's the way you do cases and you report them, and I emphasize that in the logbook, not all cases are reported. They just need to meet a certain number which has to be done. So, but it is some sort of a standard by which you can see what is happening. That the cases could be either observed, assisted, performed under supervision, or performed independently. And the SR at our hospital was very kind to share her logbook with me, which she did during her residency, which finished last year, and she passed out. The total number done in 3 years. We are a 4-year residency, but students are allowed to sit in the exam in the 4th year. So this is the logbook that they submit to the college. That in 3 years of urolithiasis, there were 297 cases that the SR was involved with, of which 120 were of urolithiasis. When I looked at the breakdown of what work is being currently done under a residency program like ours, there were, as you can see, 8 cases of cystolopexy, of which most were either performed or performed under supervision or without. And then there were some cystolithotomies, again mostly done with supervision. When you look at ureteroscopies. She had done 45 ureteroscopies, and a fair mix of both under supervision and observation. So there was some experience happening. Laser ureteroscopy the number was quite small in this period, for the reason that the laser came a little later in the last part of her residency program. And ureterolithotomy, as you can see, open surgery, there were only 2 that the person observed during this, assisted during this time of the 3-year college program. But the PCNLs were quite significant, and yet again the maximum that a person could do was to do it under supervision but not independently. And there were no pyelolithotomies done during this period of 3 years. So if I were to summarize the experience of urolithiasis, the surgical experience of any resident working in a high volume training center, the exposure of urinary urolithiasis management, surgery and management is good. There is supervision. Techniques learnt are probably satisfactory, but the confidence is not satisfactory. And the ability to perform independently is certainly lacking. And this I'm not being critical of the residency program that I represent, but I think this is across the board, except for maybe 1 or 2 places where the numbers may shift a little further down. But these residents, when they come out, when they've done their fellowship, when they are called specialist, when they go and become consultant, seriously lack the ability to perform independently complex cases and even moderate cases, and in some places the simple ones when it comes to it. So I think my first question, do we need a fellowship in urolithiasis? And the resounding answer, I'm sure, from the audience would be also a yes. And why? Because we have one of the largest number of stones in the world. We've been listening to the climate change, which is going to increase our burden of stones. We have been listening to change in technologies that's going to happening. We have been listening to even complications which are being produced because of the lack of correct management of stones. So hence, we need to have more people who can perform better and who can and can be part of it. But what should be expected from the candidate who becomes a fellow in urolithiasis? And I think here the general feeling is that the person should be able to do A, B, and C, and D, and E, F, and F independently, and probably also complication. But I do not agree. I don't think that should be the only expectation from a fellow in endourology. In my opinion, the candidate should receive expert training in stone diseases, both clinically and academically. We cannot disassociate the academic part in the training bit, because that is what we seem to be doing. When I talk to my own people, the students that have trained with me, which are many all over the country as well, and others as well, and the emphasis is largely on doing a procedure, but there has to be an element of academics involved as well. We need academically oriented endourologists, the future thought leaders in endourology, expert clinician with research contribution to endourology, and elevate the standard of care of stone diseases. If we are to be producing any fellows in endourology, this is what we are expecting that individual to be able to do and to perform and to deliver. So which centers can offer fellowship in urolithiasis? It should be a stone disease, it should be a center which has a sort of a disease mix pattern, not just a certain type of stones, but a lot of stone related problems as well. It should be a high volume turnover, and I've listed these down, and this can be discussed and argued, and the numbers can be chipped and or added, that at least 3,000 stone patients must be seen per year. And the center should be able to do lithotripsy. Yes, we have discussed, and there are pros and cons and opinions both sides that lithotripsy is coming down, but at the moment the individual center which is offering a fellowship in urolithiasis should have a fair number of lithotripsies done, should be able to manage bladder, should be seeing cases with bladder stones, with ureteric stones, where both flexible and rigid ureteroscopies are done, and a large number of PCNLs done. There has to be some exposure of, or the center should be able to offer pediatric stone disease management. There should be a dedicated stone clinic, because without it being there, you don't get the overall comprehensive management of the stones and the urolithiasis management that is required. And metabolic stone management program in consultation with nephrologists and dietitians is a necessity if you're going to have a fellowship program center in urolithiasis. However, I add here that a research laboratory of some sort must be part and parcel of the center, either its own or an access to it. So anybody who's doing a fellowship in endourology should be exposed to a research laboratory where there is some basic science, some clinical research. They translate the research into in conjunction with industry into real deliverance, and they keep a good and correct, transparent, honest database of their stone diseases. So amongst the, in my opinion, who should be a candidate who should apply for such a fellowship? Well, an FCPS urology who has an interest in endourology and is willing to dedicate time for both academic and research elements of urolithiasis, and is willing to take on the future leadership in endourology. I looked at the multiple endourology. We don't have in Pakistan a specified fellowship in endourology, so there is nothing to rely on. So one then goes over the internet and tries and sees what are the programs offered internationally and at big centers, and there they have been able to produce reasonably good fellows in endourology and urolithiasis. In many centers they have lumped laparoscopy and some cancer laparoscopy with it, but here we are talking purely of urolithiasis. So it should be this is a post fellowship 2-year, post FCPS 2-year training program, which is split 70-30, where 70% of the time is spent in clinical work and about 30% time should be spent in research. Program should focus exclusively on urolithiasis, and fellows should receive training both in surgical and metabolic aspects of managing kidney stones. It should be an immersive experience where they are given an opportunity to rise up to being consultants of the future, and they should become integral members of both clinical and research teams. Amongst the curriculum outline, the clinical expertise and surgical management of kidney stone disease using both metabolic evaluation and treatment, and again our common procedures like ureteroscopy, PCNLs, shockwave lithotripsy, and whatever you have it. In the research element of it, and I'm glad that I'm being followed by two eminent scholars who are going to be sort of elaborating in different ways, but certainly we are keeping on with the trend of academics and research in the coming two talks, that the research should, in the research they should be able to understand how to start a research project, write protocols, grants, research ethics and budgets, and work with industry and the university, and to be able to observe and learn how to manage research personnel and funds. Now, a lot of research that we talk about is pure retrospective data analysis or case studies, and this is not what I'm talking about. Until and unless we actually give them hands-on and as well as training in research methodology of the next level, where they are capable of writing grants, where they are capable of looking at the funds, where they are capable of managing the people who do the grants, they will not be able to be in the group which is researchers. They should observe and learn and to manage research personnel, give presentations, write manuscripts, even write chapters if they can. And they should learn how to work with industry partners, and this is not industry partners when I mean with no offense in organizing such meetings, but actually the problems that we have in patient care and what industry, especially device industry or other instrument industries can do for us to improve the care of the patients. The teaching, they should be able to teach visiting urologists or be part of the teaching and observe and learn, teach residents, students, and be involved with the developing material of teaching material for residents and urologists, both nationally and internationally, in order to become a comprehensive thing. And in my opinion, the work outlined for a fellowship in endourology should be that they spend 3 days in surgical experience of all these procedures, which I don't need to elaborate, which all of you are very well of. They spend time in outpatients, inpatient management, and spend at least 2 days a week in research in the basic science laboratory to develop their research skills. Now, there is a lot that in urolithiasis, microbiological techniques would help them understand biofilms. They would understand biomaterials. They could also look at metagenomics and DNA sequence. We've heard of various types of genetic abnormalities which are resulting in stone formation in children and even in adults, and they should learn or be part of the research which is pathophysiology of kidney stones, how stones fragment. We have learned that, and we've been hearing that of various mechanisms, and then they will be able to understand and be able to produce new things as well. And stents itself is a science by itself, and it has been changing. And until and unless our endourology and our urolithiasis or endourology fellows are involved in such things, they will not be leaders in that. In the clinical research, they should be able to manage the database, and the centers which are offering this fellowship must keep a database. There is absolutely no point if the center is not able to produce the data that it has of the patients and how they've been managed. They should be able to produce clinical protocols and its development, learn how to answer research questions using a translational approach, and interact with industry. So, fellowship in urolithiasis, they would become a confident expert in managing simple and complex stone diseases, can handle independently any complication arising from management failure of themselves or of others, because they will also be seeing failures produced by others. Should be cost conscious. I mean, it cannot be somebody who is not cost conscious in terms of their institution and the patient that they serve, and have to have the patient in the center of their learning. They have learned the mechanics of research, published papers, and presented to bodies, and is involved in endourology. So in conclusion, in a high burden stone disease country, experts in management of urolithiasis are certainly needed. There should be, these should be able to offer independent, safe, up-to-date and comprehensive care confidently to the patients. Clinicians who can contribute to research in stone disease, and we need academically sound thought leaders in endourology who can elevate the care of stone diseases. So I will conclude as saying that although we do not have a fellowship in endourology or urolithiasis, it is time that we should develop that. And as I have, and I'm sure there could be multiple opinions about what centers should be taking it, who should be involved in it, and what, at least in my opinion, and I'm sure there will be different opinions, should be involved in the training of such people to reach that status of being called a fellow in endourology. So thank you very much, and that should be my last line. Thank you very much.
If there are any questions, queries, you are most welcome.
Or you want to, I think it might be a good idea to lump questions to the end, because our three talks are quite interrelated in one way. That would be, I think, appropriate that we have the questions together and open the house.
So keep your questions in mind and ask in the end. Now, next speaker is application of urolithiasis lab research into clinical practices. Ahmad Adar.
Okay, thank you very much, Chairman. And I'm I'm really grateful to Sajid Sultan, who made a wonderful presentation in the morning on metabolic workup, and to Professor Zafar Zaidi, who again provided the prelude to my presentation. So essentially what I'm going to talk about is translational research in urolithiasis. And translational research essentially involves a process of turning observations which are either made in laboratory or they are made in community, they are made in the clinics, and that can be applied to clinical practice. And if we consider urolithiasis, there are essentially two major domains. The first one is the treatment domain, which essentially involves lithotripsy and endourology. And the other one is the prevention of recurrence domain. I think we have done marvelously well in the first area of management, and there's very high quality evidence available in deciding about the management, and it's very well reflected in the guidelines that we have. I think clearly we have moved a long way now to consider open stone surgery as an option for urolithiasis. So except for very, very rare situation, open stone surgery is hardly performed. And if we look at the data even coming from our part of the world, it's clear that open stone surgery, even for complex kidney stones, is really not an option. Now, we need to understand, and I think Professor Sajid Sultan pointed out very nicely in the morning, that urolithiasis is not a single disease entity. It's a heterozygous condition. It's a systemic disorder, and that's why it's very difficult to pinpoint a genetic disorder or a gene for majority of the stones that we see. There are obviously specific conditions and syndromes in which you have urolithiasis, but by and large, for most calcium oxalate and urate stone formers, it's difficult to pinpoint a factor responsible. So it's increasing, and I was happy that Professor Manzoor showed the data in the morning, 12% incidence, and this is exactly the incidence quoted in international literature. It's a common condition. 1 in 11 people in the United States have a prevalence of stone disease, which is equivalent to diabetes. So these are two endemic conditions of the modern world. So not only it has a high prevalence, it has a very high recurrence rate as well. And it is a condition which can essentially lead into serious complications, severe conditions like end-stage renal disease and cardiovascular disorder. However, the problem with urolithiasis is that it has areas of heterogeneity, which is making it such a complex condition. We have data over last 60 years from Park and colleagues et al. To now about metabolic factors, but essentially it has not translated into significant clinical progress. We need to create platform for the development of future and observational studies to find the exact reason. The fact that it's a systemic disorder, it's quite clearly indicated with other conditions associated with urolithiasis. Now, if you look at this data coming from Giovanni Gambaro's unit from Italy, and it's a survey of various European and non-European centers, the implementation of nutritional workup is seen in 62% of cases. Basic blood workup is done in vast majority. 24 hours urine, which essentially includes 16 parameters. However, 7 out of 16 parameters were performed in about half of the patients. Stone composition was assessed in about 60%. A DEXA scan in about half the patient. So this is coming from the Western world, where the incidence of disease is low and the resources are available to conduct all the workup, let alone our part of the world, which has significant resource constraints as well. So, if you do metabolic evaluation, the question really is that how much and in whom. Obviously, it's important that you not only start with 24 hours urine, you need to look at the medical conditions, the lifestyle, history, basic physical examination, urinalysis, etc., and stone composition before you embark on 24 hours, which again is a controversial subject only because that it has not been able to convert into clinical reality in prevention of stone disease. So when risk factors are found, an extended individualized metabolic workup is indicated. So this is an interesting article by Olivier Traxler and his colleagues who have talked about who, when, and how metabolic evaluation should be done. Our own assessment on this matter is that it is a controversial area, and we do require longitudinal studies in order to identify people who would benefit from this kind of a workup. Patients who have early recurrences are the ones who should be definitely investigated, and as pointed out by Professor Sultan in the morning, the children who are likely to recur many times in their lifespan and who have formed an early stone in the early part of their life should be investigated. However, we need to, at least in adult and the first time stone formers, tailor our investigation. Now, why there is an issue? The reason why we have an issue is that we lack high quality evidence to convert our observations into clinical reality. Even for the very common advice that we offer to all the patients that drink plenty of fluids does not have high quality evidence. So this is an interesting meta-analysis published by the Cochrane database, in which they've looked into all the current evidence about the increased water intake. Does it actually prevent stone disease? Now, if we look at authors' conclusion, they found that the role of increased water intake for primary prevention of stone disease is lacking. So there is no RCT of quality to indicate that it would prevent stone occurrence. However, for secondary prevention, achieving a urine volume of at least 2 liters per day has shown that it can decrease the chances of recurrence in long term. So why is that so? Probably because that compliance is a major factor. So even for asking your patient to drink plenty of fluids, they would do it immediately after getting a treatment or an episode of colic, but within a month or so they would forget about and go back to their old style. So this is an interesting study, and this is what Dr. Zafar Zaidi was pointing out, that we need trials of this nature. This is an interesting trial, and this the trial protocol was shared in the American Journal of Kidney Disease last year. And this is called a PUSH trial, which is prevention of urinary stones with hydration. And in this trial, they will be randomized patients into 2 arms. One who is going to get the regular advice that we do on a daily basis in the clinics, that drink 2.5 to 3 liters of water so that you have a 2 liters of urinary output. Whereas the second arm are going to provide these smart glasses. These smart glasses are linked to your mobile phone, and they will monitor the fluid that you are taking, and this data will be shared with your clinician or investigator. Besides this, there are going to be behavioral interventions, financial incentive, and structured problem solving to the investigation group. This is a complex layout of this study, and the primary endpoint is recurrence of a symptomatic stone in the 24 months of follow-up. So I'm sure that the findings coming out from this interesting study would be of benefit to the audience here with interest in urolithiasis. I'm not going to go into the details. It has been touched upon in the morning. The pediatric urolithiasis is responsible for significant morbidity Its prevalence in children is increasing. We have more upper tract urolithiasis now than what we used to have in children. Maybe it's an impact of our dietary habits, the use of soft drinks, the amount of protein that our children are taking is much more, and that's why probably the bladder stones are less frequent. So this is Cochrane database again review, and I'll share some of the interesting findings. I'm not going to go into the details of this trial, but essentially what this trial has shown is that, and this is about children, so oral potassium citrate supplementation may reduce recurrent calcium urinary stones in children following lithotripsy. However, the investigator's confidence on the finding is limited, and this is a standard statement that the Cochrane database has to make. A substantial number of children stop the medication due to adverse effects. There is no trial or evidence on retreatment rates in these. So we do need critically well-designed trial in children to prove that intervention that we wish to perform. Deal with on a day-to-day clinical practice. A first-time former, single stone, unremarkable serum chemistry, normal urine analysis, no family history of stones, no underlying medical conditions associated with stones. So this is a patient in which probably your metabolic workup is not likely to yield much for the benefit of the patient. Maybe for your trial it may, but otherwise not. But patients who've got type 2 diabetes, who've got gout, gastrointestinal condition associated with malabsorption, etc., are the one, and particularly now with bariatric surgery becoming more and more common, you need to analyze these patients if they form a stone to see and perform a detailed metabolic workup. Obviously, you have to look at calcium, oxalate, uric acid, and phosphorus concentration in urine and blood. What you need to assess is what inhibits stones, and what inhibits stone is citrate. So you need to assess the citrate level, and it is shown early in the morning that citrate levels is a major issue whenever metabolic analysis is done in this part of the world. We also look at what promotes stone formation without becoming part of the stone. So this includes sodium and hypernatriuria leads to hypercalciuria, and obviously we know that hypercalciuria is responsible for significant calcium oxalate stone. Uric acid as hyperuricosuria is responsible for urine, not only uric acid but also calcium oxalate stone. The adequacy of samples should also be assessed for repeated samples to see how well they are complying to the advice. So potassium and creatinine level should be done to see if the serum they are complying to your advices. Now, what I'm going to do in the next 3 or 4 minutes is to simplify the whole thing, so that as a urologist, a surgeon, we are mostly at spinal level, assess calcium. If the calcium is high, greater than 10 milligrams per deciliter, you need to assess obviously the PTH levels. You need to assess uric acid, because 1 in 5 patients with gout will form both uric acid and calcium oxalate stone, and calcium oxalate and uric acid is the commonest stone. setup, as pointed out by Zafar, that you need to have the support of physicians, your nephrologist, or other physicians who are interested in stone recurrence. Urinalysis is an important investigation, and the urinalysis, if your pH is less than 6, you're more likely to form uric acid stone. If your pH is more than 7.2, magnesium ammonium phosphate stone is what you will form. Microscopy to look for bacteria, red cells, cultures, and also the crystals. So this is a typical cystine crystal. This is the coffin lid magnesium ammonium phosphate crystal and double tetrahydron of calcium oxalate. So the pH is an important thing, and this will tell you a lot. So this simple urine analysis test is going to be a real eye-opener and give you insight about this patient's metabolic status. Now, another indication that urolithiasis is a systemic disorder is indicated by the recurrent calcium oxalate stones associated with osteoporosis. Now, we know that osteoporosis is really a condition of postmenopausal women. However, if you look at this interesting data, that the risk of osteoporosis and osteopenia, with or without hypercalciuria, is noted in patients with urolithiasis. The interesting finding is the average age of male patients who develop osteoporosis or osteopenia is only 35 years, and that of women was 38 years, so premenopausal. How would you make the distinction between osteoporosis and osteopenias? By doing the DEXA scan, and it will really tell you the normal bone density. So to simplify, and this is an interesting article, if you're interested in this, you should read this article from Margaret Pearl and Ralph Klim and Journal of Endourology. CNL, you need to see whether calciuric or hypercalciuric. If the person is normocalciuric with a calcium oxalate stone, hyperuricosuria, hypocitraturia, and hyperoxaluria is the potential diagnosis. So you need to assess for that. If your patient has hypercalciuria, and you need to assess the parathyroid hormone levels and serum calcium, obviously, and if the parathyroid hormones are raised, the treatment is quite straightforward. With normal PTH level, you need to entertain the diagnosis of sarcoidosis. So for non-calcium containing stones, which is uric acid, infectious stones like brushite and magnesium ammonium phosphate stones, and cystines. These are the three types of stone which are non-calcium containing stone. I'm going to talk a little bit about these. So these are your typical calcium oxalate stone, monohydrate, rivulite, hydrolite. The calcium phosphate are the carbonate apatite, brushite, and hydroxyapatite stones. These are your non-calcium containing stone, the uric acid, struvite, and cystine stone. So calcium oxalate stone with normal, and now the 8 diagnosis, and there are only 8 treatment that you need to remember. And so calcium oxalate stone with normal calciuric, you need to see if there is excess of promoters. And uric acid is the most important promoter for your calcium oxalate stones. Consider gout, see if there is chemotherapy given to the patient, and if the person is involved in protein gluttony. If there are insufficient inhibitors, that's the second thing you need to assess. And insufficient inhibitors is obviously in the form of citrate, or the person has type 1 renal tubular acidosis. An excess of solute like hyperoxaluria, and if the hyperoxaluria is greater than 75 milligrams per day, in the absence of short gut or malabsorption, consider primary hyperoxaluria. And there are 3 types of it. We don't need to go into the details. If your hyperoxaluria is less than 75 milligrams per day, then it is mostly enteric type, and you can correct it very simply by giving the right advice. So if you have a calcium oxalate stone with hypercalciuria, you need to do the PTH levels. If the PTH is high, then obviously parathyroidectomy, as hyperparathyroidism is what you're entertaining. If the low PTH, you're looking at sarcoidosis. Calcium phosphate stones, again, you need to look for hypercalciuria, hypocitraturia, and various other metabolic conditions. So what are the treatments? And there are only 6 to 8 treatments for normocalciuric, hyperuricosuriria, allopurinol. For normocalciuria plus hypocitraturia, potassium citrate. For normocalciuria and hyperoxaluria, you need to really improve calcium in the diet to chelate your oxalate. Hypercalciuria with increased calcium and PTH, obviously surgery. Hypercalciuria with normal serum calcium, thiazide diuretic, and potassium citrate. So the bottom line is that there are only couple of, not couple of, but 5 or 6 interventions that are required for majority of your stone patients. So in order to prevent uric acid stone, the mantra is that no acid, no stone. And you need to alkalinize the urine. The goal is to achieve a pH of 6 to 6.5. If your pH moves from 5 to 7, the solubility of uric acid crystal increases 20-fold. Low purine diet and high fluid intake. If you have an infectious stone, the mantra is no bacteria, no stone. So diligent and thorough stone removal is essential. These stones can recur in 6 weeks' time. So if your patient had a successful surgery and think that you have done a successful surgery and there is only the 4 millimeter CIRF left, this patient comes back in a couple of months, you find another significant stone and you curse yourself what you have done. You thought the patient is stone free. They can really recur very fast. And preventive doses of antibiotics can be given for 6 to 12 weeks. And maintenance doses, preventive doses for 3 weeks, and for maintenance doses up to 3 to 4 months can really prevent these infectious stones. Acetamine hydroxamic acid, which works on the enzyme, is really significant side effects and hardly used. Cysteine, we know that you need to increase your output not 2 liters but 3 liters per day. Sodium need to be reduced, and the pH has to. William Osler, Sir William Osler said, one of the first duties of physician is to educate the masses not to take medicine. And this is what I advise to almost all patients, irrespective of what kind of a workup they had, that they need to increase their urine output to 2.5 liters, for which they need to take 3 to 4 liters per day. What your patients do, and you need to ask them, is that hum to subah utke 4 glass pani pee lete hain. We have 4 glasses of water in the morning, nothing for the next 6 hours, and then a couple of glasses later in the evening as well. So that's not what is required. What is required is circadian drinking. 1 glass of hour every hour while you are awake. You don't need to really wake up and have a glass of water. That's a joke. No problem. You're supposed to laugh. Thank you. You're the only friend that I have in the audience. Okay. So they need to decrease their salt intake. So the advice is that your food should contain less salt and absolutely no added salt. So nothing sprinkled on your French fries. Low animal protein diet. And this is exactly what is recommended by the EAU guidelines. One of the things that happen, and this is a study done by one of my residents, looking at the perception of what causes stones and what prevents stone, and you'll be shocked what people think is the cause of stone and what causes, what prevents stone. Important thing to remember that all stone former will like to cut down their calcium because they're being told their stone is calcium. Whereas that's a disaster. You decrease your calcium, you will increase your oxalate absorption. So you need to take enough calcium, about 1000 to 1200 milligrams, in order to prevent hyperoxaluria, enteric type. This is interesting, and when I read about it, I didn't know that. You have a residual stone. You take soft drinks with everything that you have, food and everything, and you have Proteus mirabilis. The outcome is pretty straightforward, which is a staghorn stone. So phosphoric acid in your soft drinks, along with the Proteus infection, with a little residual stone, you will form a magnesium ammonium phosphate stone in months, and you would not have any symptoms. There are various things that you can do about it. This is an article published in BJU some years back about the use of plum juice for prevention of. Now this is another. I'll just take only 2 minutes and then I'll wrap up. That the residual stone is an issue, and this CIRF is really a disastrous definition. You need to remove those small fragments, and if there is any small contralateral stone or somewhere else in the system, should also be removed. In this work, Sorensen and colleagues have shown that removing an extra small stone anywhere else in the system would increase the operating time by 25-30 minutes, but it has a significant long-term impact. If you are able to remove asymptomatic secondary kidney stones during surgical removal of primary stones, you lower the risk of relapse without increasing surgery-related complications. So I think another important advice. We have discussed about the stone tree, and this is the data from our own unit looking at the stone composition, and you can see that pure stones are rare. So only 8 pure stones in this cohort of over 450 patients. Majority were combination with major component of 80 to 90% in about 166 patients, and complex stones with multiple chemical compositions in majority. So majority of your stone is not composed of, it may be calcium oxalate predominantly, but it has various different etiologies. So in summary, metabolic evaluation, all or for some, is really a question, and I'm not going to answer this question today, and we don't know the answer as far as I know. It's important that the follow-up strategies should be defined. Who should be following these patients? There have been talk about involving the nephrologist or the nutritionist, etc., etc. But I think it's important that the urologist stay in touch with the patient, because he or she is going to look at the complication of recurrent stones. So he should be involved in the further management. Oral chemolysis with potassium citrate is a wonderful thing. However, there is lack of compliance on this. And we do need high quality evidence in order to really say on a scientific basis what really prevents recurrence of stone. Thank you very much for your attention. So we'll lump the questions in the end. Yeah.
Thank you, Hamad, for your excellent presentation. The last speaker of this session is Dr. Liaqat Ali. The topic is upgrading strategies for academics in urolithiasis, substituting with simulative and modular teaching.
Bismillahirrahmanirrahim. Thank you very much, Mr. Chair, Co-Chair, Moderator, ladies and gentlemen. When I was coming from Peshawar to Hyderabad, it reminded me about a very famous writer, Amin Malouf, who had written a book, Samarkand. And he says, and I quote, that what's left in the city is the half-drunk gaze, G-A-Z-E, through which the poets see to it. And I say that what left in my heart about Hyderabad is love, the Indus saga, the utterness, goodness of the people. I would like to thank Dr. Javed Altaf for inviting us. Our very senior colleagues over here, Rajpur is here, Majid Saab is here. So it has been, Madam Saima also. So it has been great honor for me, sir, coming here, and it's just like my second home. I'm going to talk about something in this very academic session of academia in urology, that fortunately we all here under this roof are either the teachers or the residents. So Aristotle well said that those who know do, and those who understand teach. So this session is for the teaching. So I'd like to make, not to make you more boring for you, I'll show you some videos and also share my experience, rather our experience of IKD, that how we develop a teaching program. This is very important to say, that we need to prepare students for their futures, not our past. Because well said by Professor Zaidi, that who will operate upon you if you don't train them properly? So we have to talk something about the future urologist. And this is the status of the fair in our, this is the data of my team, as you can divide multiply into 3. 1466 elective surgery, 710 emergency surgery, out of which 156 was PCNL, URS 169, open stone surgery 35, nephrectomy 60. So we have a very huge burden disease, and we see almost 34,000. One team see 34,000 patient in outpatient. So it's a huge burden disease. And keeping in view this, and urolithiasis is just like a national disease for the urologist, and keeping this burden, I would dedicate my one share. I just added this one slide for Professor Majid Rana. कि संगे मरमर बना लो या मारो, आओ पत्थरों का कारोबार करें. So, after remove so many stones, what one can think about this? So, ladies and gentlemen, the question arises that why to teach urolithiasis? So, first step is the need assessment. Because urolithiasis is #1 most prevalent disease in the urological setups. Our curriculum is basically time-bound, outcome-based, not a competency-based curriculum. And very unfortunate, the batches, the residents which I see, because being a devil advocate, I always speak for the residents, that the residents who are haunted, the batches who are haunted by the COVID for 3 years, they have not performed anything. And there is a diversity in the training that exists from center to center nationally. Although there is so many examiners are sitting here, there is no excuse in exam in urolithiasis from A to Z, from pathophysiology to the prevention. But residents have shown reservation in multiple surveys that they are less exposed to the must-do surgeries during 3 years of residency. So one has to address this. So being a medical educator, when I see we have to, there are multiple educational theories, but the most I like is the theory of humanism, because if we fulfill these two Maslow hierarchy of need of these for our residents, that is the basic needs and psychological needs, believe me sir, they can do miracles. We have to engage them. Again, I'll say we want to have future urologists, future doctors, not us who have been trained or who have been, got all thing on hit and trial method. Now this is a good slide. Urology comes in the ivory specialty, ivory tower specialty. It's rank number 3 after the neurosurgery and the cardiac surgery. But the problem with us as compared to the Cinderella specialties is that it is very difficult to teach the skills. If you remember our internship period, or like when we were doing house job, and what happened in the medical ward, the patient and the professor say there's a mid-diastolic rumbling murmur at the apex. And 40 residents would come and place a stethoscope again and again, and they will appreciate that what is the mid-diastolic rumbling murmur. But how can you teach a cystoscopy to 20 residents? This is basically the concern of the ivory tower specialties. So there are 3 learning domains which we have to address. One is knowledge, one is skill, and one is effective domain. And all medical educators who are here know this. This is something, summary of this table of specification. Every educationist needs to love this table to understand the education. In IKD, we have structured whole of the curriculum of urology into 9 modules, including one of the urolithiasis. So in the learning domains, you can see that they have to devise the management plan, and then skills they have to perform, PCNL, URS, open stone, nephrectomy, litholipexy, etc. independently. And effective domain in which one has to, like rightly said by Professor Zafar Zaidi, that one has to add on the electives of the research, the conflict resolution, the ethics, everything to make them an academic doctor. These are the core competencies which we have defined through modified Delphi technique, which means almost 20 urologists across the country were involved, and we developed this core competency table for the urolithiasis module. Now you can see this is the very structured timetable of the urolithiasis module. This is again, and you can see that in the end we had a cricket match, trip, and dinner also. We have tumor board, we have journal club. So what educational strategy which we should employ for the teaching this thing is basically the SPICES model. We have to go from the traditional teaching of a presentation in which a resident comes here and presents, and rest of the residents are in sleep mode, or they giving text of the good morning to the one another. So that have to be a student-centered approach. We have to go for the students. And one thing, if I have an experience of adopting the student. What benefit we got from the student-centered approach is, one is methodology that is called team-based learning. If we adopt this team-based learning, you can cover 4 or 5 big topics within 2 hours. Like, I'll show you a small video of it. This is important because if you add team-based learning to your structured teaching program, you would, yeah, acha. This is This is step one, in which you'll be looking that I am explaining the setting ground rules and explanation of the TBL. नहीं यार चल छोड़ खैर ओके आप देखें जरा ऑडियो के दूसरे में ऑडियो जरूरी है जरा देख लें पीछे जरा ठीक है अब resident themselves at their homes or at their self-directed.
You are requested to please switch off your mobile phone either to vibration mode or switch off because there should be no disturbance. Step 1 इसका step 1 जो होता है वो है प्री प्रिपरेशन. अब आप अगर इसको देखें तो आपने लिखा है हमने लिखा है कि थीम है फीमेल यूरोलॉजी, सब थीम है यूरिनरी इनकॉन्टिनेंस. And we are very happy and honored that we have Dr. Madeline. She is also a gynecologist from BA. अच्छा वो होगा. And what topics we are going to cover is genital unit fistula, overactive bladder, genuine stress incontinence, and new genital bladder.
When we are given a test, a 20 MCQs or 10 MCQs, which they cover individually. This is called as individual readiness assurance test. Our director Saab said
6 out of 10.
Now you can see in individual readiness assurance test, now you give them again this test as a team in which they solve this MCQs as a team. And you see the results all score 10 out of 10. And then you add a real-time scenario, which is a real patient scenario, and then they again solve that in the team, in which they are allowed to take help from the books, they can Google it, because the only thing is that the purpose of learning should serve. Then we have to make, because as a residents, those who have not yet passed their residency, their fellowship exams, and we as a examiner, we know that the people struggle in the long cases. So one has to do some innovation in the long case. One has to take it like objective structured long case record. And I have flipped the classroom as a switching the role of Osler in the, and that I call him LA technique. ये आप देखें. This is for the knowledge domain, how to teach knowledge.
I'm relating a history of 70 years old Said Mohammed patient. The family history of my patient is because of this hematuria.
Hematuria?
Yes.
So that was a clot retention. What was the shape of the clots?
Rounded, I said. Rounded.
Longer.
Rounded.
Okay. So tell me about your examination findings. What are your differential diagnoses based upon this history and examination?
Bladder tumor, PCC bladder, upper tract PCC, renal cell carcinoma or prostata.
Now this is switching the role of Osler.
Now, present your case. So my patient, 76-year-old Muhammad Ghani, is a smoker, married man with 5 kids, is a known case of diabetes, hypertensive and ischemic heart disease.
You actually get a cytology. What is the level of cytology in this patient?
Yes, ma'am. Cytology is now, a unique cytology for atypical cells is nowadays very controversial.
Okay. Now the important thing, that was something for the cognitive domain. Now which are very, every resident and we are very much concerned, everybody was concerned about it. So how to teach the skills. Sir, we have to add into the simulation. We have to invest in the simulators. I found steps technique, which I will tell you. And we also have to now go for because we have a number of residents. I have 24 residents. So we have to introduce this peer-assisted learning also. So first of all, we have to identify a vital, essential, and desirable procedures. Then we have to identify the learning curve and the minimum procedure which have to be done by the residents. If you can see, the learning curve of the PCNL is 60, and the resident at the level of the do level of the Miller's pyramid means independent should be able 20 cases he must do in his residency or her residency. URS 40, open stone surgery 10, nephrectomy 10, litholipexy 10, and you can see the learning curve is less over here, but the number of procedures is quite high for the DG stenting because that comes in the emergency procedures. I was going through literature and I found a very good article by Professor Hamad that urological residents should be trained in PCNL during the residency period. Residents must be trained in both pelvic calyceal navigation and obtaining the access. How? Simulation, sir. Bruce Lee ने कहा था कि I fear not the men who have practiced 10,000 kicks once. I fear the men who have practiced one kick 10,000 times. So we have to add into the simulation. These are the advanced simulator. This is when we take an exam because we have to have a real-time scenarios. So this is a Sinman. So it moans, it coughs, it speaks from the control room over there. These again are high fidelity simulators. Then we have animal one has to arrange because this simulation and workshop of the simulator bridges the gap of the learning curve for the residents to be applied practically in the operation tables. Now this we arrange a workshop for the PCNL for the residents. urology workshop for the because we also teach the undergraduate medical students for safe catheterization. Then we have to switch on to the animal models and the steps technique. The step technique is this teaching a skill. First you do with commentary, then the resident do with commentary, and finally he perform a procedure without commentary. Then robust assessment is very important for finding out that whether your learning outcomes are achieved or not. So this is the MCQ grid for the urolithiasis, which we have, because we have all structured study guides, so we know at the end of each module it has been shown in the academic calendar that one would, all residents would undergo this MCQ test. This is MCQ's exam after every module, and this is the TOEIC exam after every module. Sir, if we follow these basics, some sort of principles, I would like to say for our residents that let our trainees cherish the Cupid. This is now
Bismillahirrahmanirrahim. I am Dr. Dayan, final year resident in TNC. Alhamdulillah, this is my 15th single session. And today, all the data of this patient has been done. This is a patient of non-functional kidney due to stone disease. So we are going to start with the super incision, and inshallah we will complete this procedure under the kind supervision of our supervisor Dr. Liaquat Ali. So we have opened the retroperitoneum and dissected the rota posteriorly and reached the kidney. This is the kidney. We are going to mobilize the kidney all around it. We have migrated, cut the ureter and reached the pedicle. I can show you arterial value, these are the arteries. I have applied the clamps and now I am going to cut the pedicle.
Yes, sir. So this was the PCNL under the supervision. Then there's a short video which I'll not show. That is basically about the peer-assisted learning, in which one tutor among the residents take the duties to the skill lab, do the all work of the simulation, and then bring them back. These were the cases: the independent PCNL, URS, open stone surgeries, independent simple radical nephrectomies, nephron sparing surgery, TVP, TURP, vesico-vaginal fistula. With this, I conclude that urolithiasis is an integral module of the urological curriculum. New teaching modalities, simulation, and steps techniques are very helpful in the training. Formative and summative assessment makes essential component in making the internal evaluation. And believe me, when you help the residents also pay you back, and even the administration, and there are short, token of love from them when you get a best supervisor award of the KP. And I acknowledge my services and my achievements to my better half, Dr. Saima, who is not only a very finest, she's a professor of pediatric medicine, she's not only a finest pediatrician, but also a medical educationist, looking into the neonatology group all over the Pakistan. Thank you very much, ladies and gentlemen.
I think all three speakers made very thought-provoking and knowledgeable speeches, and I think we should learn from it and try to implement the guidance which we are getting from these talks. With that, we conclude the session.
Thank you, chairs. We are going to start the resident forum, and I would like to invite on chairs Professor Majid Rana, Dr. Atif Javed, and Dr. Imran Idris Mehman. So I would like Dr. Imran to please moderate the session, and for the postgraduates and fellows who are presenting free abstracts, as mentioned in the scientific program, time is limited to 5 minutes, and so you should complete your presentation in 4 minutes and leave 1 minute for question and answers.
एक तो मैं सदा आदमी हूँ और जब मैं चेयर करता हूँ तो मैं सब लोग साथ चेयर करता हूँ। तो 6 लोग हैं तो दो लोगों को हम बुलाएंगे, ठीक है? 2 को आप बुलाएंगे, 2 को मैं, 2 को आप बुलाएंगे, और जिनको आप बुलाएंगे उनका कमेंट भी आप करें, ठीक है ना? आगे के पहला स्पीकर अच्छा किधर वही ये वाला है ना? जाकिर खड़ा है, जाकिर खड़ा है। डॉक्टर जाकिर, अगर आप इजाजत दें तो हम शुड वी स्टार्ट द सेशन? तो भगा दो ना सुमेदा। कौन था वो? जाकिर। अच्छा, we will start the session. I think I would like to remind the presenters that we will move in time, not with time. So they have to be very careful about the timings. When we ask them to stop, please, they are requested to stop it. I think this is a learning for us that how to finish your presentation within the given time. I think you cannot take it unlimited. I am sure you all know that now in Europe and Western countries, there's a timer on the screen. And once your time is up, the screen goes blank. So we will move in time basically, and I request my first speaker, Dr. Rabia. She is from Shahid Mohtama Benazir Bhutto Medical University, Larkana, and this doctor is speaking about efficacy of dusting versus popcorning laser technique in patient with ureteric stone undergoing ureteroscopy. अच्छी बात है। अच्छा हुआ, ठीक है, अच्छा, हाँ बस ठीक है, टाइम बचा लेंगे हम। Thank you very much. She is not around, so we will request Dr. Marukh Kamal from JPMC. She is going to talk about utilization of Moore's stone score in the definite diagnosis of patients with clinical suspicion of ureteric stone. Dr. Marukh Kamal.
Yes, sir.
Thank you very much.
Assalamu alaikum. Assalamu alaikum. My name is Dr. Marukh Kamal and I am resident urology in the department of urology in JPMC Karachi. I'm going to talk about the utilization of Moore's stone score in the definite diagnosis of patients presenting with ureteric colic in the emergency department. So basically, the need for an invasive intervention for the management of ureteric stone is investigated by the help of radiological imaging. The reference standard test for the diagnosis is basically plain CT-KUB. However, it is time consuming, expensive and leads to unnecessary radiation exposure. Therefore, efforts have been made to identify uncomplicated ureteral stone cases in order to reduce unnecessary imaging, reduce the costs and duration of the hospital stay. So basically our study included patients who were aged 18 to 60 years, pain originated in the flank region radiating to the groin and either gender. However, pregnant females and those patients who were undergoing kidney transplant or required dialysis or had a known solitary kidney disease were excluded, or those who did not submit a urine dipstick sample, patients who were already under urological treatment, and those referred from other hospitals as diagnosed cases of nephrolithiasis were also excluded from the study. The patients who presented with loin to groin pain with a clinical suspicion of ureteric stone were included in the study. Stone score was calculated for all the patients. Patients were graded into 3 categories according to the stone score, that is low, moderate and high risk. And then a CT scan was advised and then followed up with the confirmation of findings. Now what is Moore's stone score? A Moore stone score was devised by Christopher L. Moore. It consists of 5 parameters consisting of the gender, that is male, you're graded as 2, and if it's female, then the score is 0. Timing, that is the duration of pain to presentation. If it is less than 6 hours, it is graded as 3. If 6 to 24 hours, then it is graded as 1, and if it is greater than 24 hours, it is graded as 0. Race. Now this was controversial because since we have no black people in Pakistan, therefore in the studies that were conducted in our part of the world, it was decided that this would be, that no matter what the race is, the score will be given as 3 to all the people who would present with the suspicion of ureteric colic. Now, nausea and vomiting. Those who presented with none, they were graded as 0. Those who had nausea alone were graded as 1, and nausea and vomiting were graded as 2. Erythrocyte, that is present, hematuria on dipstick, if it was present, they were graded as 3, and if it was absent, it was graded as 0. Now the results were calculated, and approximately 106 patients were included in our study. The mean age was 39.2 years. There were 66 men and 40 women who were enrolled in the study. The duration of pain in patients that was less than 6 hours was 33%, in 6 to 24 hours in 45 patients, and more than 24 hours in 26 patients. There were no black race individuals. 60 patients had no symptoms of nausea and vomiting. Only nausea was reported in 20 patients and vomiting occurred in 26 patients. Microscopic hematuria in urine was present in 70 patients and it was absent in 36 patients. Now on the basis of low, moderate and high risk, we concluded our results. 30 patients were included in the low risk category and 14% of the CT findings were positive for ureteric stone. In the moderate risk individuals, 40 patients fell in the moderate risk group, and 50% of the CT findings were positive for the ureteric stone. However, in the high risk group, 36 patients were included in the study, and 90% of the CT findings were positive for ureteric stone. Another study that was conducted in Quetta during November and December 2020 showed very similar results. They also graded the patients in 3 categories. Approximately 16% of the CT scans were positive in patients who fell in the low risk group. 54% CT scans were positive for patients who were classified as moderate risk, and 85% was positive in patients who were classified as high risk group. Another study that was conducted in Yale University School of Medicine showed out of 76 patients who fell in the low risk group, 9.2% of the CTs were positive for ureteric stone. 51.3% CTs were positive for the patients who fell in the moderate risk group, and 88.6% of the CTs were positive for patients who fell in the high risk group. So based on a study result, CT scan and ultrasonography are standard diagnostic tools for suspected ureteral lithiasis, but the use of stone score to categorize the patients as low, moderate and high risk can help the physician to basically reduce the unnecessary burden that is on our radiology department, and to basically let the clinician decide if there is a further need of investigation or not. This concludes my presentation. Thank you.
Well done. You still have to stay there. Thank you very much for your presentation. My question is that once you have categorized into these low, intermediate and high risk, what was done after that? I mean, suppose the patient presenting in high risk group, what was follow-up?
Initially followed in the emergency department, and then after when the CT scan was done, they were followed in the OPD. The findings were compared along with the Moore stone score, and those who fell in the high risk group with a positive CT scan finding of a ureteric stone, they were then further planned for procedures like URS and whatever the stone size was.
Now,
according to the size of the stone that was.
now I think it's a wonderful presentation, but I still want to ask that you have categorized into 3 categories. And the problem is that then with the high risk, still you are calling them to the outpatient clinic, and for the low risk group also, they're coming to the outpatient clinic.
So when they presented in the emergency department and if they were categorized in the high risk group and they were advised to follow with the CT scan, they were also given the emergency treatment that was required then, like analgesics and alpha blockers and whatever, depending on the symptoms that they presented with. Sometimes the patient presented with no urine DR samples, so they were also advised for the urine DR samples and they were advised to follow the very next day because the report usually comes in 4 hours.
Now, once you have already quantified them into various risk groups, did you take, for example, a high risk group, because in your center I know that emergency CT scan and emergency ultrasound is available. Did you subject them to these investigations and further follow up?
The emergency CT scans are not available at our center because only CT scan plane is available. We usually ask the patients to get the CT KUP if done in emergency privately from like any other hospital and then follow with the report the next day, or if they sometimes get it privately and the report is available within 1 or 2 hours, then they bring it the very same day and then they are treated accordingly.
Thank you very much. Wonderful presentation. Very good. Thank you very much.
So next I call Dr. Mubin Iqbal from Indus Hospital, Karachi, who will present Demystifying Tubeless PCNL, a comparative study to determine post-op pain and analgesia requirement between tubeless PCNL and standard PCNL technique.
Assalamu alaikum to all my colleagues. My name is Dr. Mubin Iqbal and I'll be presenting my study on the demystifying tubeless PCNL. That is a comparative study, that is an RCT basically, to determine the post-operative pain and analgesia requirement between the tubeless PCNL and the standard PCNL technique. So, since morning, we know PCNL is now the standard choice of treatment for the renal calculi because it's less morbid, better stone retrieval rates and high success rates. And now basically PCNL has 3 techniques. That is the first one is standard technique that is used with the PCN tube at the end of the procedure. Another one is the tubeless in which you only left patient with a ureteric or a DJ stand in place and you do not keep a PCN tube. And third one is a total tubeless, that is no tubes placed at all. So my comparison was between a standard and the tubeless technique. Okay, what was the rationale? Tubeless PCNL is considered safer and associated with reduced pain and analgesia requirement. Although the complication rates of both standard and tubeless PCNL are almost the same in the literature. Our aim of doing the tubeless PCNL was to decrease morbidity associated with pain, reduce analgesia use in the postoperative period. Further, to pave a way to a better and a less invasive postoperative period. That was the main aim. What was my objective? As I told earlier, to determine the outcome of the patient in terms of post-operative pain score using the visual analog scale requirement in between the patients who underwent standard and the tubeless PCNL. What is the visual analog scale? Everyone knows it's just a scale to assess the pain on a subjective level. This is the scale which rates 0 to 100%, that is no pain to severe intolerable pain. What was the methodology? This study was conducted at the Indus Hospital, Karachi. Study period was November 21 to March 23. Sorry, it is a mistake. November 22. It's November 22. No, November 21 to March 22. That was study was conducted. Inclusion criteria is written. The patients who were excluded were the patients with congenital anatomical abnormalities, further the iatrogenic trauma, which was assessed by the urology, which was assessed by the operating surgeon at the time of the operative period. If there is iatrogenic trauma or much bleeding, then the patient was excluded from the study. At the same time, we divided the patient into 30 groups. Total sample size was 60, and we divided them and we did a snooze envelopes protocol. Group A was standard PCNL and group B was tubeless PCNL. Okay, these are the results. There was no such significant p-value was found in the gender, age, except in the stone size, which was 0.019, but that is not very relevant to my study. The thing which is most relevant to my study, my study is about visual analog score. So VS score on we assess the pain at 6 hours and then 12 hours and then after 24 hours post-operatively. At 6 hours there was no significant p-value, no significant differences were found even on 6 hours than on 12 hours, but after 24 hours patient had a significant relief of pain. This is the graph showing tubeless and standard PCNL. As you can all see the blue curve which shows a significant difference, but if you see the VS at 6 hours and 12 hours, even it's very it's much better than the standard PCNL. My conclusion was that values presented in our study is closely resembled to the other studies which was done previously, but no statistical difference noted except VS assessment at 24 hours post-operatively. Obviously, my study's limitations were single center study, it's a small sample size, or I might get a better results at the VS 6 hours and VS 12 hours, and obviously it's a subjective assessment. So it varies with patient to patient. Thank you so much. That is the end of my presentation. If you have any queries.
So thank you, Mubin, for such a wonderful presentation.
Thank you, sir.
It was a very nice study. Just one or two questions that whether what post-operative analgesia did you give to the patient in both the groups, and did you do any local gave any local analgesia as well? Number one.
Right.
And number two, that did you categorize these patients according to site of puncture as well, because anatomical differences might result in different perception of intensity of pain?
The answer to the first question is every patient which undergoes PCNL in our setup has a routine analgesic used, that is one NSAID and one paracetamol. So that was given to every patient, even in the tubeless group and the standard group, first one. If a patient pain score is moderate or high, then we had to use another painkiller, that's a weak opioid or tramadol. That was an additional pain, and I haven't written in this study, but standard every patient, at least 8 patients in the standard PCNL group required an additional dose of analgesia, which in the form of the weak opioid, but no patient in tubeless group required an additional dose of analgesia. That was also a good finding in my study. Second, to answer your question, did I categorize on the basis of the puncture? No, I did not.
I have one question.
Right, sir.
It's wonderful that you see you have started following the path of doing some research. But as you know, that visual assessment score was available since 2002.
Right, sir.
And it has documented in multiple papers that tubeless PCNL has less pain as compared to any size of the tube. Now my question is, once the fact is established in 2002, what made you go through this research again into 2021?
Because there is no research available that is from our country, Pakistan. Second, I haven't seen any institution which is doing tubeless PCNL. I might be wrong, but I haven't seen or I haven't heard. So I needed to confirm that it's a better way. We can do it. If a urologist sees that there is no iatrogenic trauma, or as Professor Srikant in morning sessions, afternoon sessions said, there are no chances of infection as assessed by the urologist, then tubeless PCNL is a good option. It's a very good option.
I think I need to, just for the resident's sake, I need to say a few things. I think once you're doing a research, it is get into research itself. But I think you need to make sure that whatever you're putting in so much enough effort, but you need to realize that what is the requirement in the world so that you can get it in published. Or there are two ways of getting it published. Either once you are doing a research which has never been done before. Number two, you look for the journals which will publish your research. And actually, sometimes when you submit a paper, they will immediately ask you a question that what your research has added to the existent knowledge, and then probably then you will be lagging behind. Second thing is, seeing these presentations, I think I need to mention again and again urologists are very bland people basically. You know, they play into dark cavities, their life is dark as well. And the worst thing is the presentations are totally colorless. I mean, white and black are no colors, my dear. We have to have the shades of life as such. So basically, I just want to recommend, because we were talking about that there's something wrong with the multimedia. I think I would suggest for all residents, when they are making a presentation, it is the font should be the Times New Roman, because number one, without making it a bold, it looks very nice. The heading should be size 44 or between 40 to 44, and the content should be basically size 30 to 32. And you can choose the color. I think the best color is the yellow color. And the slide should be colorful enough so that basic purpose is that the audience needs to focus as the content of your slide, and then probably once they look at it, there are high chances that you will be read. Thank you very much, wonderful presentation. I would have an advice for you that because you have such a modern hospital you have come from, use this VAS, and then there's the intermittent self-analgesia machines available in your hospital. So next year I would like to see you presenting that data. Well done.
Just a brief comment on the impression, but probably this is probably a supplementary study you have taken out from some larger study. That is, that's what you said, that it is basically you wanted to see the overall efficacy of tubeless PCNL. So that's why probably the things have, that's why it gets a bit confusing. But otherwise it was wonderful study.
So the last paper of this session is role of flexible ureteroscope with holmium laser in larger size stones. Dr. Arsalna Javed from JPMC.
Assalamu alaikum. My name is Dr. Arsalna Javed. I am resident urology from JPMC Karachi. This is not much colorful, but some colors are there. Okay. So basically, I would like to present a paper, role of flexible ureteroscope with holmium laser in 10 to 35 millimeter renal stones. So this was a study which was conducted in Department of Urology, JPMC Karachi. Objectives of the study: to determine the efficacy in terms of stone-free rate and safety of flexible URS with holmium laser in 10 to 35 millimeter renal stone with fewer complications and without ancillary procedures. So basically article search was done, and in this article search, in modern era, the prevalence of kidney stone is increasing due to effects of increasing obesity, diabetes, change in dietary habits. As we all know that our lifestyle has changed, so due to these reasons, we are more towards stone formation. Introduction. The management of renal stone has always been a subject of great debate. Treatment options available for renal stone ranges from ESWL to open surgery, subject to stone factors and other patient's factor. Introduction is still continued. The treatment of stone size 10 millimeter to 35 millimeter in form of ESWL versus over treatment can be in the form of PCNL is still debatable. Currently, PCNL remains the standard procedure for renal calculi greater than 2 centimeter in size, but it is contraindicated in patients with unfavorable characteristics like uncorrected coagulopathy or such. The introduction of flexible ureteroscope with holmium laser is emerged as the third and most optimum option in renal stone. Flexible ureteroscope is used to treat small stones, which ranges in size from 1.5 centimeter, but there are studies which are showing promising results in larger stones. So, material and methods. It was a descriptive study which was conducted in Department of Urology, Jinnah Postgraduate Medical Center, Karachi from June 2021 till June 2022. We included 70 patients in our study, and all the patients were above 13 years of age. So we have divided our patients into 3 groups. Group 70 were the total number of patients. Group A includes 35 patients of stone sizes ranges from 10 to 15 millimeter. In Group B, there were 21 patients of stone sizes 16 to 25 millimeter. And in Group C, there are 14 patients of stone sizes ranges from 26 to 35 millimeter. All procedures were done under ureteral access sheath. All patients receive antibiotic therapy, most commonly as prophylaxis with ceftriaxone. So if your ureteric access sheath failed, then DGES stent placed for ureteral dilatation and RIRS was done after 2 weeks. URS access sheath size is 11 FR, which is 45 centimeters. Flexible ureterorhinoscope size is 7.4 French. Holmium laser lithotripsy was performed using 272 and 365 micrometer laser fibers. Laser setting were based on stone volume and density, and post-operatively patients were giving antibiotics for 2 to 3 days. Post-operatively stone clearance of the patients were assessed on X-ray KUB and ultrasound KUB after 4 to 6 weeks. Data was collected on structured performa and was analyzed on SPSS. So in Group A, stones were dusted because of smaller size. In Group B and C, mostly stones were fragmented. Inclusion criteria, as I have already told, that inclusion criteria ranges from the age 13 to 16 years, irrespective of the gender. Stone sizes, which were divided into 3 groups, were 10 into 35 millimeter, and patients who do not want PCNL. Exclusion criteria is patients with active UTI and pregnant females. Total, there were 70 patients fulfilling the inclusion criteria, and mean age of the patient was 35 plus minus 4.5 years. So we took 70 patients, and we have 65% were male and 34% were female. In Group A, 33 patients, that were 94% were successfully treated. In Group B, 17 patients, that is 80.9% were successfully treated. And in Group C, 8 patients, that is 57.1% were successfully treated. The duration of the surgery of all 3 groups ranges from 30 to 120 minutes with a mean time of 57.21 minutes. So this is the total patients underwent RIRS is 82.85%, and 17.14% of our patients underwent ancillary procedure. So the ancillary procedure which patients underwent is 25% of the patient had a need of redo RIRS, 58.33% of the patient underwent ESWL, and 16.66% of the patient underwent URS. So our results were there. 3 patients had developed complication. In first patient, during procedure, there was a iatrogenic PUJ injury, which was managed by DGES stenting. Second patient developed sepsis postoperatively. Third patient admitted with the diagnosis of post-procedure subcapsular hematoma. Both patients were managed conservatively. Renal function profile also remained stable after the procedure. So, the conclusion of the study is flexible URS with holmium laser is extremely safe and effective procedure in management of any size renal stone with good results. We may need ancillary procedures like redo RIRS, lithotripsy, URS for larger size stone with no renal damage. Thank you everyone.
ब्रावो, जबरदस्त भाई, वाह. सवाल ये पैदा होता है मैडम, 3.5 centimeter का stone, if you fragment it into 1 millimeter, probably you are converting it into 90 fragments, and you have taken 2 hours. Any measurement of heat production, the water pressures there, any idea that what is going on, how much water was used for 3.5 centimeter stone, and I guess there were 14 stones were up to 3.5 centimeter, and the procedure was successful in 8 patients. So what was the thinking behind approaching these big stones with the RIRS?
Sir, actually we have certain inclusion and exclusion criteria. So we have included the patients in for RIRS. The stone were larger in size, and obviously our choice is for standard PCNL. But we did RIRS because of unfavorable circumstances of the patient. Like patient is not fit for GA, if patient is not fit for general anesthesia, or if patient have uncorrected coagulopathy, then we went towards RIRS.
Should I quote it from your conclusion? That RIRS is safe for whatever the size of the stone is?
Yes, there are multiple studies which are done.
Let me finish. That concluding remark says that no inclusion and exclusion criteria. Come what may, we will treat every stone with RIRS.
No, there should be exclusion and inclusion criteria. Because PCNL is the standard.
But you will do RIRS.
If there is inclusion and exclusion criteria, patients are not fitting in certain criteria.
Wonderful. This is very good. I wish next time when you present, we will have a slide added on for inclusion and exclusion criteria.
Okay, thank you so much, sir.
Thank you very much.
Wait, hold on. Stay there. I have a So, the 3 complications, which group were they in?
Ji sir, the 3 complications which happened, it happened in stones of larger size.
Okay, so less clearance, more complication in the larger size.
Yes.
How many scopes did you break? Flexible cystoscopes, they were all disposable.
No, it doesn't break.
Not a single flexible ureteroscope broke in 70.
No.
That is the conclusion, sir. That is an unbelievable record. In 3.5 centimeter pelvic kidney stone done with a flexible ureteroscope, 14 of them and none broke. Are you sure?
Yes.
Well, I rest my case.
Thank you very much.
Thank you so much.
Sanna, wonderful, very nice presentation. Very good. Thank you very much. We end up with this session, and I'm sure I made you sort of lively again. Thank you. Thank you very much. And I thank my co-chairmen as well. Thank you. Thank you.
Thank you, dear residents, for coming up and present your nice work. We are going to start our last and very interesting session on challenging cases, basically. And we are having many cases, but we have selected with the permission of seniors. I would like to request Professor Ahmad, Professor Zaidi, and Professor Chandrasekhara, please come on the stage. Chair the session, please. Dr. Mahesh Adhikari as well, please.
Sit on the corner because you have you have a case, right? Yeah. But you have to go there. That's why he's in the corner.
We have selected 4 cases out of 10. One will be presented from Islamabad, and one be from Ladkana, and one be by Professor Srinath Chandrasekhara, and one from LUMS.
Thank you very much, Javed. Let's start this concluding session of the. I have the details. Challenging situation urolithiasis. I'll first invite Professor Ayaz Khan to present the case. I mean, these are challenging cases, so I would request audience to please participate, and if we can have a mic available for the audience. So there is a mic there at the back.
Would you like to take your seats? Thank you. Thank you.
No, our department has started off a survey, and the radiologist has requested us to
Yes.
see what needs to be reported on CT. So I've added that CT volume as a stone volume. They even don't report downstream units. No, we don't routinely do it. You need to have somebody who's dedicated.
What's the pin? Okay.
सर्च इंजन में डालो. नूरियाबाद पे होते हैं बीच में. कहानी नहीं है, 1 घंटा ज़्यादा लगेगा. ये इंस्टॉल करना पड़ेगा ये वो सॉफ्टवेयर.
The game pin
1086627. ये इंस्टॉल करना पड़ेगा पहले.
Okay, go.
माजिद का नाम लिख दो. माजिद का नाम. ये क्या इसमें सॉफ्टवेयर डालना पड़ेगा?
Bismillahirrahmanirrahim. Assalamu alaikum. Good afternoon, everybody. After a long, tiring day, I think it's a bit of time to waken up, a bit of testing for all of us. So these are a few interesting cases. I would like to try to be very to the point, and we want to quickly finish the session, because after that we have to take a bit of rest and have Gala dinner at night as well. So I have a couple of cases. I'll go through very quickly. This is a 38 years gentleman who presented with to me with hypertension and having left flank pain for the last 6 to 7 months. Doesn't have any other significant history. He's been taking a lot of water, so had a lot of frequency, urinary frequency. He has a past history of right kidney stone surgery and a history of left-sided shockwave lithotripsy. So his baseline was normal. He was pre-diabetic. His cultures were done, urine, and they were negative. And this was the CT scan, which was showing 12 millimeter of stone. At this site, you can see at the upper pole, quite in the lying in the parenchyma, and it was painful with a history of ESWL for this stone times back, but that he said that it has no effect, and the stone has enlarged with time, basically. So this was the Ausfield unit. So what are the treatment options? So
is there any other view of the
sorry,
CT?
couldn't place that. We have another view with the contrast studies anyhow, but that will come later on. So these are the treatment options. Should we repeat an extracorporeal shock wave lithotripsy? Should we go for percutaneous nephrotomy, or should we do an RIRS, or leave it as such? Having he just have mild pain off and on. Yeah, please start. What should be the option? And moreover, one thing that the patient was of the view that my lithotripsy is not, it's not effective. So I have done it once, nothing has happened to my stone, and rather it has increased in size. So the option is RIRS. I think we also tried to attempt the RIRS. Okay. Third RIRS, fine. Retrograde intrarenal surgery. No, I was taking. It's okay. Question A. So we opted for RIRS, as all of you have given your opinion. Can we play it? I would like to skip a slide. So this was basically the RPG effect picture. So what do you think? What should we do now? He's in pain. Now what we should do?
1 centimeter की बात नहीं है, ये कहीं से excess ही नहीं हो सकता.
What's the diagnosis for the residents? Where is the stone? Stone is in the calyceal diverticula, basically, right? So we have.
आज रेजिडेंट होगा तो बताएगा, सारे कंसल्टेंट बैठे हैं.
So anyhow, it was a difficult situation. Actually, it was very difficult to manipulate the flexible ureteroscope actually.
So you opted for flexible ureteroscopy?
Yeah.
And you have seen the CT scan beforehand. It was a contrast CT?
No, it was a non-contrast.
Non-contrast.
It was a
But the
non-contrast.
location of the stone was quite telling. The only picture that you've shown us,
Yeah, it looks
is
like-
quite telling that it's very, very peripheral.
yeah.
So it's likely to be a glacial diverticulum
Yeah.
stone. I have voted for percutaneous procedure because that's the only way of getting that stone. Although it requires a bit of an expertise.
Yeah.
The only way that you can do it is to hit the stone and
we had
make an
that in
access,
mind basically, but actually it was very high-lying kidney. It's very high-lying kidney.
Can I make
so-
a comment, please?
Yeah, sure.
Also, I'm skeptical whether the cause of this pain is due to this, unless there's ongoing infection. Because this is nicely embedded in the kidney, so it's very rare for
He didn't have any
such a stone.
infection. Yeah.
No pain.
No infection. He had mild pain.
So, I would start there by asking whether there's any other cause for pain, because if there's no infection, this stone is unlikely to cause pain.
Yeah.
That's my view.
You may not pick up infection if the neck is absolutely closed. He's had lithotripsy, and the stone even didn't break in the lithotripsy.
Yeah, he said.
There's hardly any space around that stone for lithotripsy to fragment. So this is a story. I mean, I absolutely agree with Professor Srinath that you need to ascertain whether this pain is related to the stone, and you have to treat this patient by all means to take care of this pain. And if it doesn't, I have had a couple of patients in whom we end up doing percutaneous procedure because the patient really forced you into doing it.
Actually, this patient had been taking a lot of analgesia, off and on.
Yeah.
It was a mild pain he had been taking for a year or two, analgesia off and on, and he actually came over that I have to remove it because, that is going to help me. And he was working in an oil field company, so I mean, kind of a scare that I would be
occupation is another
occupational thing. So
indication.
that was his main, fear.
As when before starting, you did an RGP retrograde because you didn't have a contrast CT before
I didn't have it.
before the CT.
Yeah.
So did this calyceal diverticulum fill with contrast from below?
Yeah, you can see it. You can see. Sorry, can you show it, please? You can see the very narrow calyceal neck. Yeah, yeah. Probably it's not very clear here.
Presentation दिखाएं.
Yeah. Unfortunately, we could not paste the non-contrast film here, but actually this is the contrast in the diverticula.
Actually, there's a small line of
very narrow,
thin line of
very thin line of contrast.
I have come across a similar case. Even after contrast CT, I didn't see the CT properly, and then went for RIRS. And then during the surgery, I came to know this is a diverticular stone.
Yeah.
Then we did a blue speech test, contrast, Then tried for a RIRS, then completed with RIRS. There's a small line, but that's a quite long infundibulum. May be difficult sometimes.
Yeah.
So PCL would be the right choice for this.
And try and open the neck.
In this, actually, the kidney was really very high lying, and it was in the upper pole. Like I was just counting the ribs where I have to go and have an entry to the diverticula. So that's why we opted for an RIRS initially, and also the patient was very reluctant to go for PCNL because somebody had told him that it would be very difficult to getting it punctured as it's the upper pole. And so he was also very reluctant for any other surgery than the RIRS.
So, I mean, in situations like this, and particularly for those who are not very good with their punctures and they're still in the learning process, that a good radiologist can help you in the operating room with an ultrasound. Remember that the ultrasound approach is moving towards the stone, whereas if you do the imaging and retrograde as a media of identifying the calyx, you puncture and then you withdraw the needle. So that's not possible. You have to feel the needle by going as close to the stone using an ultrasound, and then feeling the stone on your needle and making a track. So it requires expertise. This is a very difficult case.
continues to leak?
It's a diverticulum which would not be producing its own urine. So either you can access it, the neck of the diverticulum, and dilate it and let it drain into the system, or you can Majidrana Bugby the calyceal diverticulum.
So you managed to puncture it with the PCNL. No, you did a RIRS. So if somebody is doing a PCNL, they could go straight into the diverticulum, take the stone out, and then probably do a methylene blue flush from below to see where it is coming out, and try and get a fine guide wire through that, and maybe then increase it into size so that it continues to drain in future.
Yeah. So actually the baseline is most of the times the PCNL is the first choice in these cases, and you dilate the calyceal neck and you can put a stent if you want to, right? But I mean, we tried it with a flexible RIRS, though it was very difficult with that, but anyhow, it was done without any complication.
We're talking about PCNL in a diverticulum, stone in a diverticulum. If you were not able to get contrast in from below, would you be, because you mentioned PCNL, then you would ask your radiology colleague to come and puncture it for you?
I mean, Mahesh would probably puncture it without ultrasound guidance. He would just put his needle and feel the stone and make a
hit the stone. Yeah, you can do it without that. I mean, if it's just because it's all filled with the stone. I mean, you can just go straight away. It's like feel the stone and just.
This is a challenging case, no doubt. But the lesson, another lesson, as Prof. Ahmad said, is you see this very frequently in lower pole stones, because you see a lot of lower pole stones, and the calyx is so filled with the stone, there's no contrast going there. So as Prof. Ahmad said, you just go straight on this, as if it was the retrograde study, to the opacity of the stone, and you feel the needle grinding on the stone, and you know you're right there. So just the wire. Sometimes even the wire doesn't go through, so you just need to dilate onto the stone, and you put the sheath, and you then, with a bit of clearance, you see the stones.
Yeah, most of the even in the huge stones, Tagon stones, you don't have any contrast. You just have to feel the tip of the stone and put the wire and dilate. So we went for the RIRS. Both could have been opted. I mean, could go for PCNL as well. So anyhow, it was.
The diverticular stone. Another problem is it's difficult to put a stent in that space. Space is very narrow.
Another trick which one can do if you have a very limited space is to bend the tip of the guide wire slightly, so that when it goes and touches something, it starts to curl up rather than puncture through it. It works very well, especially. Or a sensor guide wire.
You mean while doing the PCNL?
Yes, if you're doing the PCNL.
And it's better to put a curled end wide glide wire. So, and there were actually multiple stones.
That's an ultimate challenge to your skills to be able to maintain your instruments where you're dilating a track to approach the. So this is a difficult situation.
Don't try it.
Not for the faint-hearted.
And this is we placed the stent and it came out of it. We all popcorned the tiny stones. These were actually small multiple stones.
Did you do the blue speed test?
Yeah.
Methylene blue
test.
No, we did the RIRS, so this was not needed.
Actually,
we did it with
cut it and entered.
Yeah.
Do you see sometimes if you can't see the orifice clearly also?
No, we could see that. It was very thin, but I could see. I mean, I would just.
Blue dye will guide you to
the
stones.
Yeah, sure. But most of the time, that's most helpful in the PCNL, percutaneous punctures. I mean, I could see it with the flexible scope here. So.
Right, thank you very much, Dr. Yaz. I think it's a very interesting case, and it's a real life situation, can happen to you anytime. So, could I request Professor Malik Jalbani to present his case? Struggle with the body to decide whether you form a stone or become diabetic. Obvious choice, right?
take extra metformin and just have
Diabetic stone formula.
extra metformin and
out of us.
Safe enough to treat when they had complications, severe complications, they were discussing the hematoma and rupture.
Thank you. Thanks to Chair. Assalamu alaikum. This is a 5-year-old boy presented with left flank pain, which is gradual in onset, and it was mild to moderate intensity and associated with the nausea according and the vomiting according to the mother of the boy. According to the labs, his hemoglobin was 9.9 gram per deciliter, while his TLCs were the 9,000. Urine DR was multiple RBCs, pus cells were plenty, urine CS was showing no growth, and the viral markers were negative in this patient. These are the CT scan. This is a CT scan of this patient. You can see this. So what are the options you can think about this patient?
What size was, you haven't mentioned the size given by the report?
It is
stone.
about 11, more than 11
millimeters. And
it's just at the level of the PUJ or the upper ureter.
Are you loading the pole? Somebody loading the pole? Do you have a pole for this one?
it's not working. I think we should just go ahead and ask what people would do.
Otherwise, we have to go to the.
Otherwise, we'll be here every day. So who would do lithotripsy on this? All right. Who would do?
Sorry,
you would do
not 11,
lithotripsy.
but the 20 millimeters. Sorry.
2 centimeter.
2 centimeters.
2 centimeter stone. Now you have also backed out. So there's no taker for lithotripsy. Who would do RIRS? And probably JPMC. Because they would do it. You would do a RIRS. Yes. Who would do PCNL? Mini PCNL, whichever PCNL that you have. So, why would you do RIRS?
So the reason being is this stone is at the
UJ.
Plus this stone is around 20 millimeter, and because of the availability of the instruments and the expertise, one can go ahead with RIS. Then I don't see any contraindication of doing that.
But practically, the armamentarium for the RIRS is not available with us.
Okay. But you have a rigid scope.
We have rigid scope.
You don't have a laser.
We haven't laser.
Okay. Would you do a lithotripsy? Rigid ureteroscopy with lithotripsy, with a lithoclast?
But there's a high likelihood that the stone will get pushed into the system.
And you get pushed into the system, then you put in a DJ and then carry on with what you want. But would you attempt it?
With the rigid, no.
No, you're not. Okay. Why not?
For the same reason, because if you have availability of flexi and
See, the patient is 5 years old, 2 centimeter stone. It will take long time to break.
Well, the problem is in children, if it's at the proximal end where it is, there's a long way, and this ureter will have to be, UO has to be dilated. In most scopes, you'll have to have an excess sheath, unless you have a 4.5 centimeter 4.5 French scope, and you will have to go up, and as even with a laser, it is likely, because you will be using an holmium, there's a lot of possibility, a lot of fragments would probably go in, and 2 centimeters is large. It's not a small, it will take a long time, there'll be a lot of heating around there. So I think if somebody, for those who mentioned, I won't do a URS, I would do a PCNL. So those who mentioned PCNL, what would be your approach? Upper, middle, lower, supine, prone? Yes, because if you come in from the upper pole, you can go very much straight into the ureter, and easily can go into the ureter, break it, pull it up into the kidney, and then do the rest. If you try it from the lower pole, the angle may be too much, and you may cause damage at the PUJ. Sorry? You could, yes, but I mean, it depends upon which is more dilated, which is easier to.
Definitely, the option was either we are supposed to go from the upper pole or from the mid pole. But when I have done the RPG, the kidney was high up, and only the option was available through the lower pole. And as you have already mentioned, that the problem was that angulation with this, I cannot reach in this stone.
In that case, the best option would have been a rigid ureteroscope and break and push it up into the kidney and put a DJ in. You can always do lithotripsy or whatever, or puncture it from the top later on.
So you have 1.5 centimeter of fragmented stone. 1.5 centimeter stone in the fragmented stone in the lower pole calyx, which fails to clear with lithotripsy.
So, कहते हैं कि मरता क्या ना करता पेशेंट को ट्रीट, तो definitely we were supposed to treat him.
Yeah.
So then we put a rigid scope and 4.6 French to 6, and then we put a stone cone above the stone. We have fortunate enough that we have reached above that, and
you went back from below.
Yes, from the below.
Okay, so you managed to get a stone cone.
So fortunate enough that we have get the stone almost cleared through. The video is this. You can see this is the stone, and cone is this. This is the cone, and this is the point from where the cone is supposed to open, and this is the wire which is going up, and you can see here that the wire is going up above the 12th rib, even above to that, and it was difficult because in this boy it was very much possible to puncture the lungs. So to avoid this, we have done this. Next video. Next. So you can see how the cone is coming and fitting over the stone.
Yes, we saw that. What size is your ureteroscope?
4.6 to 6 French.
So your 4.5 centimeter FR ureteroscope plus is 6 French of this as well.
Yeah. Fast. So this was the stone.
4 French. 4 French.
0.038 inch.
So this was the fortunate that we have done this job, and the patient was next stone was cleared.
Proximal ureteric stone of that size, even you are able to clear the stone, there's a possibility that there's a stricture permission in the future. So you need to be very...
So this will be followed definitely.
Yeah,
it will
very
be followed.
regularly.
I'm not sure that's a fact or a myth.
It's a fact.
PUJ, no, that's stricture being formed there. Because we've done many, and I can't give you it. It'll be all anecdotal. And do follow them up, and there's no hydronephrosis, and we don't do it with a contrast study. So I have not come across stricture. But stones are impacted. In children, they are often very much impacted. Secondly, I think there is a unfounded, but I suppose lack of experience, fear of puncturing above the 12th rib. Because you can, if those who do upper pole puncture would not fear this kidney and puncture from the top.
Because it was medial to the supraclavic scapular line. That's why I was fearing that when it is a medial to that, the chances of the puncturing the lung is very much high. If it is lateral to that, then it is okay. Otherwise,
yeah, okay. For I think those who don't do it, yes. Otherwise, for those who do it, would feel quite comfortable about it.
Thank you very much, Professor Jalbani. I think that's an interesting case, and you have done a good job. Can I request Professor Srinath to present this case, please?
Still don't stop. Why should you?
No, this is straightforward middle school. This is such a dilated system.
Yes.
stay here.
Because you could see it had already dislodged from its place and you could see that in the hole.
Okay. Yeah, okay. So this is a, I think, elderly guy, about 65 or more, maybe let's say 70. He came to us with bilateral loin pain. His renal function was elevated. Previous attempt at stenting in a provincial hospital had failed, and you can see the stent which is below the stone on the right side. He has had pyelolithotomies on both sides, and on the left side twice. DMSA showed reasonable function, better function on the left side. So PCNL was attempted. And on the left side, massive hemorrhage was encountered during lithotripsy. They gained entry and they couldn't do much of a retrograde because there was not much dye going through, but they managed to get the puncture, and massive hemorrhage was encountered during initial intracorporeal hemorrhage. What are the possible causes? Yeah, yes.
Was there a CT or anything done before this?
No, unfortunately not.
And a horseshoe was ruled out?
Horseshoe was ruled out. It was not a horseshoe. So, but it was reported that there was severe bleeding during initial bit of lithotripsy, and they managed to do lithotripsy, and then as they progressed, they just found very, very severe bleeding, and blood pressure started dropping. So the question is, what's going on? Do you think this is a parenchymal bleed or a major vessel bleed? Any thoughts? No bleed in diathesis. Coagulation is okay. The question is, they couldn't figure out what it was. So, I mean, this is not the crux of the question. So, they couldn't figure out whether it was bleeding from the parenchyma or whether there was any major injury. So, let's proceed with the. Okay, so majority think it's major vessel bleed. Okay, so they couldn't figure out what is going on, and a retrograde study was done. Any findings? I think this is more of a discussion rather than questions. That's the retrograde is on the side. I would like the panel to comment. I'm sorry, Professor Hamad has seen this slide. This is the slide that has traveled with me most in the around with conferences.
I'm keeping my quiet.
Okay.
You can see the ureteric in the ureter.
Okay.
So clearly it's there, and he's had surgery done before.
Yes. No, the image. Yes, sir.
That's a bit. What would you say?
It's a track in the ureter. It looks like in the ureter. I'm keeping quiet because I told you.
Yeah. Yes. So we couldn't get, I mean, these guys couldn't get a retrograde done. So there were a lot of things that were not right in this case.
So they didn't even start with the retrograde?
They didn't get a good retrograde in because they couldn't get the wire, or because if you look at the stone, I believe that middle part of the stone was blocking. So they didn't have a good retrograde study. So by the time I was called in.
So they punctured blindly?
No, they managed to puncture onto the stone. So by the time I was called, this is the first image I had.
So they probably hit some vessel, that's what it is.
Yeah. So anything striking in this, Mahesh?
What is that tube? Is that tube?
So that's the ureter, that's a retrograde catheter there.
That's the sheet, that's the implant sheet.
That's the implant sheet.
Dilated, and they started
They dilated, gone in, and if you look at it from the original slide, the stones have now fallen somewhere down into lower calyces.
So it's very much at the hilum, isn't it?
Yeah.
They punctured at the hilum.
Sorry? I don't know, I'm asking. Yes?
Then it is.
Yep. Where do you see the pelvis here? Yeah. Yeah, so there is a problem here. So what we figured out is there was hardly any renal pelvis in this patient. He has had previous surgery, so stone are just stuck there. There was hardly any pelvis. So this is the next thing that we found. Sorry. So we decided that we were going to put a balloon and tamponade because the patient was bleeding. They were pumping in blood. Blood pressure was not right. Renal function was not good. So what are the treatment options? How can this patient is bleeding? What can you do now? Patient is prone on the table. Okay.
It's too big, and your tube seems to be going up the IVC.
Arterial or venous? The major vessel is what, artery or vein?
It's on the left side. It could be the artery. It's unlikely artery.
Venous bleed. So for large vessels of this size, where the catheter
can't
is
embolize
going,
them.
you can't embolize.
So let me add, patient is unstable, blood pressure dropping, blood being pumped, patient is prone on the table. Well, 2 pulmonary thoracotomies before. How long do you think you'll take to get there? Yeah. So if you think, you think patient will survive till you explore through a previous 2 pulmonary thoracotomies?
Yeah. No, but even
yeah. I would ask the experts.
So you could put in a Fogarty and just blow up the balloon.
Yeah.
Because that will go under vision and then open and do whatever you have to do.
Absolutely.
Because
sir.
by the time you'll even put him in position and get your instruments,
Yeah.
he would be dead.
Yeah. So the lesson here, I travel with this. This is my travel companion. Everywhere I go, I take this case because this is the scariest moment I have had in my endourology life. So this guy was just gushing out. Blood pressure was dropping. he had 2 big scars done in the provinces by non-urologists. So the thought of opening to get any control was absolutely not a possibility. So we had to contain in whatever way. The good thing, I'll just explain, I'm sorry I'm giving you a lecture here now. What we found was that there was no breach, so there was no contrast going out of the system. And when we tried to get not a Fogarty but a large catheter, you can see that the catheter is going up, and as Prof said, this is going up the IVC. So later we found out that the guy who was doing the PCNL had just broken through into the IVC through the renal vein. Yeah, from inside, not from outside. So just gone through from inside the kidney into the renal vein, and the catheter is going up the IVC.
So that makes you and Hamad best friends, because you also showed us a case very similar to this.
This was an Islamabad meeting that the shiver down the spine presentation. And do we have time? Okay. So this is.
Yeah.
Finally.
If you want to continue, we will be more happy.
Yes, Prof. Quickly. Yes.
So the story is that a 17-year-old boy with a renal pelvic stone, uncomplicated PCNL. Obviously, the nephrostomy tube, which is the cause of all problem, was placed by a resident. It is always the story. And the nephrostomy tube, according to the resident, is going nicely down the ureter. Next day, as a protocol, we declamped the nephrostomy tube. And as soon as the nephrostomy was declamped, there was liters of blood gushing from the nephrostomy into the bag. The patient collapsed. Fortunately, some sane person on the bedside clamped the nephrostomy again. We did the studies. We found out that from the right kidney renal pelvis, the Nelaton catheter has gone into the renal vein, all the way into the IVC, and all the way into the right heart.
So very similar to this. I think, Hamad, I copied you on this.
So now you have best friends.
We have been doing things not knowing that we are doing the same things.
So let me show you the other images, and then we are going to follow Professor Rana to dinner. So that's the subsequent images. So you see the upper pole blowing up, the catheter going up the IVC, and then we somehow managed to struggle a wire down the ureter, and God's grace, we managed to get a stent in as well. And that Amplats was blocking the IVC till we got our act right and wiped the sweat off. And you see the contrast going right up the IVC there on the other slide. So the savior was, as he said, a tamponade catheter. We just put a balloon, Foley catheter, cut the tip off so that the tip doesn't go into the IVC. That's the day I started using this zero tip, because the moment it with the Foley was in the IVC, started bleeding. So we cut the tip of the Foley and inflated with it contrast so that we knew exactly what was going, and we contained the hemorrhage till the patient was stable later on to go for a nephrectomy. So this is the scariest moment I have had in my endourology. So this guy does a lot of traveling with me. Thank you.
Is there a regular practice to do PCNL without any contrast study?
No.
Not after this.
Not after this, number one. Number two, I was called in between, but I may not have had a chance because there was no contrast.
PCNL without any contrast,
Yeah, so two things. One is I wouldn't have done this case without a CT, number one. But I would have done it if the retrograde wasn't filling, as we discussed. Sometimes when the stone is filling the calyx, you can't get any dye in. But I would have certainly had a CT with 2 pyelos in the past. I personally wouldn't have done this case without a CT.
No, and that CT probably also a contrast CT.
Absolutely, yes.
Pre-operatively, so you know what is where, what it looks like, and people tend to just go on plain KUB X-rays or plain CT, and that's for those who have been operated before. It's important that you know the anatomy.
I think this discussion came up yesterday when Professor Hamad was talking about the importance of CT. I don't operate on upper tract without at least a non-contrast CT.
But you don't do a contrast CT on all of them. I agree with you, except for those who've been operated before, certainly twice. The anatomy will be distorted for sure.
But by the time I got into this case,
too late.
Those discussions are not relevant.
Yeah.
Thank you.
Should we conclude the session? हाँ इसीलिए तो जा रहे हैं.
जी जी. Dr. Majid Rana will persevere while the rest of us will find a way out.
You are the one. It was a workshop. It was a workshop. It was a workshop. It was a workshop. He was there. One side is it wasn't bleeding a lot, but the contrast is flowing into the eyes. It was on the right side. I said, I know I went out and it wasn't bleeding away. But when I put on the contrast, it was good.
Bismillahirrahmanirrahim.
Thank you very much, Dr. Majid Rana.
It's a very usual presentation of stone disease with the flank pain, right flank pain since 6 months, and it was gradual in onset, mild intensity, intermittent, dull in nature, and he has a history of open renal surgery 2 years back.
It was stone. It was stone.
Yeah. So look at the scar which is on the left side. Rest of the examination and laboratory examination was unremarkable. So here is a CT. You can appreciate the right renal stone, a residual stone after surgery, and there is also a left renal stone. Can appreciate what he has, the unusual anatomy which you can appreciate from residents. Yes, obviously the left renal surgery was done on the horseshoe kidney open surgery, but there are residual stone you can appreciate here on the CT. But patient has a flank pain. The other images. So there is a horseshoe kidney, operated kidney on the other side.
Go back.
So what is the plan?
Get a contrast study done.
I think the contrast study may be comparable when you are doing retrograde. So it will give us an idea of renal pelvic calyceal system easily.
Not necessarily, because in a non-functioning element also you'll put in contrast, you'll get an anatomy. Anything which is sort of closed off will not get the contrast from below, and you will also see it, either functioning or non-functioning elements of it. Something, because open surgery often can lead to the pelvis being so tight that it becomes closed or extremely narrow. So a contrast study helps.
But we are not planning on the side of open
Yes,
surgery.
but this was a horseshoe. We don't really know what was done where.
But looking at the CT, the contrast, the cortex is pretty good. So that's why with the ultrasound, and we can easily appreciate the cortex, so we can assess the functions as well. The retrograde is, I think, sufficient to assess the anatomy.
Would either of the panel agree that looking at the cortex on a film is good function? No?
No, actually.
That's a common That's a common myth here, that if you have a good cortex, it's functioning fine. Yeah, that can overestimate. If it's obstructed, certainly can.
Okay, what is the plan? Obviously, with the horseshoe kidney, nobody will open on the other side. So the plan would be preferably the PCNL. So if you look at this is a retrograde film. We have placed only the guide wire into the system. So can we assess the system in this picture?
This is not a guide. This is an open-ended.
Then open-ended past.
Yeah. Put in the contrast.
Guide wire, open-ended. Where is the stone? Obviously, the contrast study will tell us. The retrograde film that shows the horseshoe kidney, but you can appreciate here there is the lower pole stone having a 2 moiety, and different moieties have the stones, and it is mal rotated towards the skin side, maybe because of the contralateral operated kidney. So it was very difficult to assess from the upper pole. Generally we assess the horseshoe kidney, we puncture from the upper pole because of the easy access. But look at this picture after putting contrast, and when we prone it, then you can assess the upper pole is the very much different angle than the lower pole. And in the lower pole there are three moieties, and in 2 moieties there are the different stones are there. So which puncture you want to prefer?
No, so you can get it from the upper pole because you have a nice track down and you can bring your...
It requires long length nephroscope if you have. And there are 2 different moiety stones in the lower pole. Because the challenge was after puncturing the kidney, the challenge was we enter from the lower pole of the lateral moiety, which was bit anterior towards the skin and easily punctured in that, and we easily placed the guide wire and passed into the ureter.
Yes, but the danger of you damaging the PUJ is quite high over here, as well as the anomalous blood supply. It's a horseshoe.
Yeah. But when we get in,
onto the stone.
थोड़ा speed up. Next. Finally, we retrieved all the stones. One video is missing here, and then on the other moiety, just we lift up the kidney with the implant sheet, and we easily place the implant sheet in the upper moiety of lower pole, and then we retrieve it all the stones. This is the final picture of the fluoro.
Single function.
So you managed to get across to the other side from here.
Yeah.
That's what you're saying. Very good. Very good. Thank you very much. I think very interesting session, and interestingly also well attended as well as participated. So thank you very much. I think that concludes today's session, and we will ask the organizers to decide what next. Thank you very much. This could have been done as an
Very difficult lower polar stone.
We will have the inauguration session and the dinner at 7:30. 7:30.
I went at